I think the hardest thing for the public to understand is when they file a complaint, they're doing it because something has happened. Unfortunately, we can't change what happened to their loved one, but if it is a situation where we can go in, then we can, by golly, do our best to prevent it from happening again.
Welcome to In Good Company.
In today's episode, we're joined by three leaders from the Missouri Department of Health and Senior Services, the state agency dedicated to protecting the health and safety of Missourians through public health programs, senior services, and healthcare regulation. Our guests include Michael Fields, who oversees home health and hospice regulation, Tracy Niekamp, who leads long-term care regulation, and Rebekah Stone, who directs hospital regulation. Together, they share insights on how DHSS works behind the scenes to ensure quality, safety, and compassionate care across Missouri's healthcare system. Welcome to the show.
Great. Thank you for having us.
One of the things that I've always wanted to kind of point out to people that is, you know, we've had a home health, hospice, and home care agency for about 15 years. We've had a lot of experiences with the state on several situations, whether it's a complaint or whether they've done, you know, a survey for us. And it has always been a very positive experience. And one thing that really got brought to the surface to me was how many people don't know how many people you guys are protecting through the work that you do. And so I really want to bring that to the surface of all the things that you guys do and how you help protect the general public and making sure that people are getting great care.
Great.
So let me dive in first. So this goes out to whoever. Can you tell me about what is your state organization? What is its mission? And how many people are in your particular division?
Great. So John, I'll take the question. So we actually, all of us, Mike and Rebekah and myself, we work for the Division of Regulation and Licensure. But our parent department is the Department of Health and Senior Services. So within the Department of Health and Senior Services, there's many different divisions. But the Division of Regulation and Licensure, we have about 390 full-time employees. And so we regulate everything from, as you said, home health care, hospice, ambulatory surgical centers, in-stage renal dialysis, long-term care facilities, adult daycares. Truly, our division, you will end up touching someone from birth to death. And if you have an opportunity to touch healthcare. So our mission is to promote health and safety through prevention, collaboration, education, innovation, and response.
Love it. Love it. That is a great description of so many things we could potentially unpack here. Can you, generally speaking, each one of you is kind of in charge of a different area. So generally, what are the, what are the kind of background of everyone who works in different divisions? Like what's the training involved? What are the credentials, that sort of thing?
So in long-term care regulation, we hire a variety of individuals. So we hire a lot of registered nurses. We hire licensed practical nurses. We also have folks with experience or degrees in sociology, psychology, environmental science, just a wide variety. When we do a survey, we are required to have at least one registered nurse on that survey team. And many of the complaints that we look at are related to quality of care that requires a registered nurse to really be able to fully unpack what's going on with that particular case. So that's predominantly the type of folks that we hire. Here in this section, we have around 200 surveyors that we employ in a variety of areas. And our training, or the background that our staff have, they come from a wide variety. We have everyone from having worked in an emergency room in a hospital to having long-term care experience, to private agencies or organizations. So just a nice wide background of individuals who work in long-term care.
So for the Bureau of Home Care and Rehabilitation Standards, we our two primary provider types are home health and hospice. And just like Tracy has in long-term care regulation, we're also required to have a registered nurse on our survey teams. But as John well knows, in hospice, it's a multidisciplinary approach where you have social workers, physician, counselors. And so we also hire people that are subject matter experts in those areas also. So we have certified grief counselors that are part of the hospice survey team, social work background, and along with the registered nurse. And we really try to have, like I said, subject matter experts hired in the Bureau. And I think all areas are like that. So the people who come in to do an inspection or a survey on a home health, a hospice, a hospital, or long-term care facility are, kind of experts in those areas. And a lot of the work we do is federal work for the Centers for Medicare and Medicaid Services. And to become a surveyor for CMS, Centers for Medicare and Medicaid Services, you have to go through a substantial amount of training and kind of go through check off surveys. And it's probably a good 6 months or longer in most of these places before you hire, and from the point you hire someone until they're even minimally competent to do anything on their own. So they're never alone because we always have a survey team. So that's kind of the background for the Bureau of Home Care.
For hospital standards, it's very similar to what Tracy and Mike stated as far as what our process is. We, in hospitals, typically are heavy on the nurses. In the years past, we have had a dietitian here, there, and yonder, and maybe a pharmacist, I think, at one time. But currently, we have 14 full-time nurse surveyors, and those are registered nurses, and we have one licensed practical nurse. And then we have one part-time nurse surveyor. Combining that with our triage coordinator, our complaint coordinator, our licensure coordinator, and then office admin, we have about 21 staff that make up Bureau of Hospital Standards. So we do hospitals only, and that encompasses about over 160 hospitals throughout the state. Missouri's a little bit different because we have 2 metropolitan areas. So you have a larger number of facilities located in St. Louis and then across the state in Kansas City area. So that's a little different than some of the other states have under their jurisdiction. We survey, investigate complaints, and regulate and ensure compliance at acute care hospitals, long-term acute care, psychiatric rehab, psychiatric residential treatment facilities, critical access hospitals, and rural emergency hospitals. So along with that, having said that, there is one set of regulations for some of the providers and then another set for another. And then if we go in and do an Emergency Medical Treatment Act, which is formally known as EMTALA, involving an emergency room patient, then that's a whole nother set of regulations. Then you have your psych regulations. So there's a lot. So when we all talk about the training process, it's very overwhelming. I was a surveyor with Bureau of Hospital Standards for 11 years. And when I came to the Bureau, to the state, trying to think back, I had been a nurse for over 25 years at that time. And honestly, the first 6 months, I questioned myself, what have I done? Because it was so much to learn.
Right.
And I guess I was so comfortable in my previous, I knew what I was doing every day in my role. And then to come in and, have that overwhelming feeling. I kept thinking, I'll never get this. I'll just never get it. And we're very similar to home health care as far as about 6 months or so, combination of online and in classroom training before we let them go out and start interviewing and stuff on their own. They still have a lot of supervision, but honestly, we tell our new staff, it's going to take 2 years for you really to feel comfortable. And it does, just because of the number of different providers that we regulate and the number of regulations. And then it's just so complex. And not every on-site investigation or survey is the same. It's always something new. But we predominantly have registered nurses make up the most of our field surveyors.
So let's talk about ongoing training, because I can only imagine with all the changes in regulation and changes in healthcare in general, that has to be, let's talk about that. What does ongoing training look like for your survey teams?
Sure. For nursing homes, for our surveyors who go into the skilled nursing facilities that are certified for Medicaid and Medicare, for their initial training, for those surveyors, it takes about 9 months. So it's a very prescribed training process that includes virtual training, classroom training, on-site training. And then after that, all state employees are required to have 20 hours of continuing education training that they're required to do just as a state employee. But then the Centers for Medicare and Medicaid Services, they have specific training requirements that we are required to do as well. So there's 2 different types that they are required to do. One is called foundational skills review. So that's just going back to make sure that the surveyors are continuing to be knowledgeable and able to identify when there's a regulatory practice, being able to do that. And then also there's a surveyor skills review as well that happens every couple of years. So the learning, one, never ends, the testing never ends, but then the additional curveballs are when regulations change, right? So I know you guys can appreciate that as a provider, that the regulations often change. And so that's additional training too. But that's from long-term care.
Yeah, Tracy's right about the training. Yeah, it never stops. It's a moving target. It really is. And just for instance, in the last 2 years, John can attest to that, the hospice regulations changed,
Mm-hmm.
And a year before that, the home health regulations changed. And every single time they change, we have to develop new tools, do training, and then CMS requires training also. And yeah, it really is a moving target. It's funny that we're talking about regulations because I was speaking at a hospice conference last week, and one of my slides was a photo of all my manuals stacked up. It's 1,180 pages.
Oh my gosh.
that my surveyors have to know. And it's ridiculous, right? So you can't possibly memorize all those things. And, when we're there for a week during the survey, there's no way that we can look at all those. We have state statutes, we have federal rules. We do OSHA stuff. We do life safety code stuff. Yeah, it's a significant amount of work. But so we do continuous training. Like Tracy said, we have a minimum amount of training. But for instance, just alone, most of my surveyors will do about 200 hours of training a year.
Mm-hmm.
Yeah.
Wow. That's impressive.
Basically the same to what they said as far as the training for our staff. And then as the administrative staff receives emails with the updates or revisions or anything like that from CMS, then of course, communication's the key. We discuss it at the admin level and then roll it out to the staff. We have staff meetings twice a year because otherwise our surveyors are telecommuters, so we never see them. They don't come to the office per se on a routine basis. So that's another thing. One thing I wanted to go back and add to Bureau of Hospital Standards, because something that I am very, I don't know if I want to say passionate about, because it's been a big learning curve for me since I've taken this position almost 3 years ago. But we also license hospitals in the state. Obviously, that kind of probably goes without being said. And then we also oversee the construction renovation processes. So it's just a lot. You have the
Wow.
regulatory aspect of it, then the licensing is kind of separate, and then we have the construction and renovation. So I've learned a lot about fire codes and different things like that. I never thought I would know or need to know.
Well, having said that, like the level of commitment to this field is pretty substantial. I mean, it's quite a bit, obviously, of education and understanding and supervision and that sort of thing. I'm going to switch it a little bit to the personal side here. Do you have like what got you into this, and do you have any personal experience being on the consumer side that helped drive you to want to be more on the, how do we protect the public?
Well, I can start. It's really about me getting into nursing. I had a very personal experience with that. When I was around 11, 12 years old, my grandma developed Parkinson's dementia, and she lived with us because her husband couldn't care for her. So I got to see home health nurses come out to the house, and walk her through that. And the funny thing is, sometimes she would have to go to the hospital. She wouldn't eat or drink. She'd get dehydrated. And my home health nurse actually picked up shifts on the weekends at the hospital. So the same home health nurse would be in my house, and then when we go to the hospital, she'd be working in the hospital, which was crazy to me. And then when she got near the end of life, we switched her to hospice, and it was a whole different set of nurses come out, and it left an impression to me about the nursing field in general.
Mm-hmm.
That's kind of what led me down this path. It's like you never would guess a 350-pound football player would go into nursing, but here we are on the podcast. Right? Yeah, that's kind of what led me down the pathway where we're at now.
That's great.
Yeah.
I can go next. I'll be honest, it wasn't my first choice of a profession. I actually wanted to be a cosmetologist. But I don't know why I didn't never pursue that. I worked at a newspaper right after high school and got married very, very young at the age of 18, and then decided, hey, I want to be a nurse. I think I was always the caretaker. I liked to do things for others and take care of everything. Maybe my family would say that's a control issue, but I didn't say that out loud. But I think that's what led me down the path. And it's been a great career as a nurse. I've always had to been able to have a job that I was able to put my family first. I worked years as, in the hospital, don't get me wrong, but I always worked it out for the shifts to work good with my kids when I was raising kids. So it's been a good career. And here I am. So
yeah,
Bureau of Hospital Standards.
Great.
That's awesome.
So I am the non-nurse out of the group. So my degree is actually in sociology. And when I graduated college, I worked for a county organization that provided, they had a group home for individuals with intellectual disabilities. And so I ran the group home for about 5 years. And I was just looking for a change. And so I applied to work for the state. We were the Division of Aging at the time in social services, and was hired as the surveyor as part of some legislation that was passed that was called the Alzheimer's Demonstration Project. And so received my surveyor training and really fell in love with long-term care, fell in love with the residents, and seeing the difference that we make. I started in 2001, and it's just amazing to me how fast the years have gone. And just being able to really make a difference every day is why I keep coming back. So
I love it. So I mentioned before, our experience with the state has always been, they've been great at education for us, making sure that we're covering all our bases appropriately, holding us accountable. So having said that, in each of your fields, and we're speaking to the kind of general public right now, in what ways do you feel like kind of like low-hanging fruit, so to speak, for when you're going into, a facility or into an agency and you're like, okay, these are the first things I'm looking for to protect the public. What are some of those things?
I'll go first this time.
Okay.
Sorry, Mike. We have a hard job of being the regulators because nobody likes to see us walk in the door. Unfortunately, we don't generally get to point out what good things are being done. We only point out the failures and what needs to be corrected. So a lot of the low-hanging fruit, as you mentioned, when we're looking, is safety. I think that's one of the number one things that, we're there for a particular condition of participation, at least for hospitals. And so, yes, that's our focus, and that's what we're going to investigate too. But we can't put our blinders on if we see something over here that's an infection control issue, but that's not what we're there for. Because our end goal is, I truly believe, what the provider's end goal is, and that's patient safety and good care. We want good outcomes for them. We want that as well as the hospital does, or any provider for that matter. So it takes a lot of observations and just general awareness and thoroughness.
So let me just dig into that just a little bit more. So when you say safety for the general public, what does that look like from a very practical standpoint? Like, what are the first things you're looking for?
Well, from the minute we walk in the door, if there's hallways that are overloaded with equipment, would it be an issue if there was an emergency to evacuate patients or move patients? When we're on the inpatient care units in the patient areas, we look at the same thing. Are there medication carts unattended? Are there crash carts opened? And that's not just for that involves everybody. That would be an issue for potentially staff, visitors, and patients. So we're kind of looking at everybody. We just typically do a lot of observations and don't need to ask some questions initially because that's part of the process. Just eyes and ears and taking it all in and seeing is there something that just doesn't look right? And then you go on down that road.
Okay.
That answer your question?
Yes.
I need to have one part edited. I need to let my dog out because he's
okay. Okay, you go for it. You go for it.
So I can go next if that's all right, Tracy.
Yeah, please.
Like safety and the low-hanging fruit. Rebekah said something, conditions of participation, and let me define what that is because the public may not understand what she's talking about. So in order for a healthcare provider, whether it be a nursing home, hospital, or skilled nursing facility, in order for them to bill Medicare, they have to meet conditions to participate in the Medicare program, and they're the rules, essentially, the CFRs, if you will, the Code of Federal Regulations. So that's what the conditions of participation are. It's just another word for the regulations, essentially. So my provider types are a little different because when Becky walks in and when Tracy walks in to do a survey, those people are there in the building. The patients are there in the building. when I go in to do a survey, I go into an office building somewhere and there's no patients in there. It's just staff and paperwork, you know. But our low hanging fruit really is when we pull their complaint log and we interview the patients when we go out and do home visits, because we follow the clinicians and nurses to do visits in the home. For instance, you have a hospice patient, the nurse goes out and visits. One of my surveyors or myself will go and watch the visit. And our low hanging fruit is pain and symptom control in hospice. We really want the patients comfortable and have their needs met. And that's really the low hanging fruit. And trust me, with all those regulations, we could be writing deficiencies every week, but we don't do that. We have good common sense. And if the patients are being taken care of, we look at every regulation through the lens of how it affects the patient. And every single observation, every single chart we review, if the facility, agency, provider, if they put the patient first, that's the most important thing to us. And, you know, a lot of these little deficiencies that we could write, we don't. We just say, hey, by the way, clean this up next time as you would. As long as the patients are getting good care, that's our main focus. But for me, it's pain and symptom control. And in home health, it's just them following the orders to get the patient off of home health and, you know, back to their lives as quickly as possible, not to be dragging it out, you know, just to keep billing, you know, so to speak. So as long as they put the patient first, that's the most important thing for us.
That's great.
Yep.
So for long-term care, as far as low-hanging fruit, you know, everything that we do is based on observations, interview, and record review. Like those are the three basic components of everything that we do. So when I think about observations, the low-hanging fruit is as soon as my teams are walking into those long-term care facilities, what are they smelling? Right? Like what are they seeing? What are they smelling? What are they hearing? And so oftentimes that is probably the low hanging fruit for us, right? Is just, you know, we walked in and, you know, things do not smell well in this long-term care facility. And so kind of following the path then of what's going on in that community. When I think about low hanging fruit with record review, it's some of those like paper citations, you know, that we may have, like, you know, maybe somebody's done a background screening, but maybe it's 1 or 2 days late or something that, yes, they're in regulatory compliance, but, you know, maybe they didn't hit it exactly on mark. And then when I think about interviews, the low hanging fruit with an interview is the conversations with the residents about how staff treat them. Those are, you know, just those interviews are so not to lessen it at all by calling it low hanging fruit. That's the foundation of what we do, right? Are those interviews with the residents. So, but those are the things that kind of come to my mind of like, what are those kind of low hanging fruit items?
Yeah, our experience has been very positive. Like we feel like they've been extremely fair with us, and it always kind of came from the criteria of how, like, if they found a problem, how serious the problem was, how many times that occurred with that one patient, and then how widespread is it to other patients that are on caseload and maybe are off caseload or whatever. But it always seemed like they took a very scientific perspective on it. Like it wasn't just they found the problem. It's like, is this a one-off mistake or is this a chronic problem that this agency really needs to address? A couple of things that came to mind when I first started thinking about, you know, protection, and was really just how empowered that those patients and those families are when they run into issues in the different agencies or facilities. and 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 what can they do? Like, how do they know? It's this balance, right? Between, because I've always said, you can have great customer service and get really bad care.
Mhm.
Like, those two things can be true at the same time. And so, we're always cautious when we're talking to our leadership team, when I'm like, well, how's that clinician doing? Like, one of the first things they sometimes say is like, well, we've never gotten a complaint on them. I'm like, well, that doesn't mean anything,
Right.
because we're talking about a generation that doesn't like to complain, first of all. And there's a whole host of psychological reasons behind that. But, when we're really trying to dig in on, like, what are the things that we're most concerned about, some of the top of the things on the list are obviously infection control and medication management. So in your particular areas, what are, if besides those two things, and we can talk about those things as well, are there other things that you are really like zeroing in on as far as making sure about that patient safety?
I wanted to add on to what I said earlier, because Tracy hit it on the head. We don't just do observations. We also do patient interviews, staff interviews, record reviews, policy reviews. So when Mike explained the conditions of participation, and thank you for doing that, we refer to them as COPs. The failures that we see have to rise to the level of condition level, meaning there has to be systemic failures, so not isolated events that could be corrected. We as well will share those as concerns if it is, because we very seldom do deficiencies at the standard level. It's either enough to make the condition level out of compliance, or we don't cite. So that's kind of how the hospitals do.
Can I stop you there for just a second before you move on? Can you help explain to the general public who aren't probably familiar with standard versus condition, what that would mean to them?
So let's say the condition of participation for patient rights. So then you have, that's the condition level deficiency. Then you have standard tags underneath that. So the standards would be looking at restraints, care in a safe setting, let's see, and investigations that on something that occurred. Those are some examples of the standard tags. So if we had an issue or a failure found, that would fall underneath, we're there for the COP, the condition of participation for patient rights. And the issues that we found were egregious enough, systemic enough, then we would cite those standard tags, but we also would cite the condition level. So our phrase is, it takes the condition out. Basically, they're out of compliance at condition level.
Okay.
Which, if that occurs, then the hospital has to come up with a plan of correction that has to be approved by the state agency and CMS if it's a deemed facility. I don't want to get too much into the weeds because there's a whole bunch of stuff I could talk about.
We don't have to go there.
Extremely confusing. So if it is under CMS jurisdiction per se, then they have to also approve the plan of correction. Then we make a revisit at some point in time. There's time frames for everything. Then we would go back on site and do a revisit survey to ensure that they have corrected. And we don't survey or investigate to the plan of correction. We're there to ensure there's no current non-compliance. And I think I want to also mention too, in the hospital world, survey is one thing, investigation is another.
Okay.
90% of our workload is complaint driven.
Okay.
And that has really changed over the course of the last 12 years since I've been with the Bureau. We saw a drastic increase starting to uptick right before COVID hit. And then it really went to the sky during COVID, and it sustained that for a while. And we've just recently kind of crawled out from that era. But needless to say, unfortunately, our complaint volume is still a lot more than it used to be. We receive in hospitals over 2,000 complaints a year. And I'm speaking the last few years. We're over 200 a month. And I think the hardest thing, and sorry if I'm jumping ahead here, this might be a question coming down the line, but I think the hardest thing for the public to understand is absolutely when they file a complaint, they're doing it because something has happened to their family member or their loved one and their world, basically. And I get that. But there's a process that we have to follow through the triaging of that complaint. Every complaint gets reviewed, triaged, we call back every single complaint. And we have one complaint coordinator in Bureau of Hospital Standards. And a lot of our field staff are out in the field doing investigations, so they're not there to help her. We always joke with her that when she retires, we don't know what we're going to do because it's a hard job. She's got a very tough job. But, it's very important to that person, that complainant filing that complaint. But I think the hardest thing for us to convey to them and get them to understand is we can't possibly go out and investigate every single complaint we get. So we have to have a triage process, and it has to rise to the potential level at condition level before we really can go in. Or if it's a deemed provider, then we have to have CMS, Centers for Medicare and Medicaid Services, authorize us to go in. If it's a non-deemed provider, which are generally the majority of critical access hospitals, then we have the ability to do that authorization process. So, a lot of times it's very hard because even though I'm not the triage coordinator or the complaint coordinator, I get a lot of the phone calls. Sometimes when they call the governor's office, then they will send them to me. And I'll do a lot of explaining, and and I get it because they don't want to hear that. They just want to know, what are we going to do about what happened?
Right.
And to add to that is, unfortunately, we can't change what happened to their loved one. But if it is a situation where we can go in, then we can, by golly, do our best to prevent it from happening again. And sometimes that's all they want to hear.
Yeah.
They're dealing, sometimes they're grieving, they've lost a loved one, and sometimes they just want somebody to listen.
Oh, definitely. Tracy, Mike, whatever, do you have anything to add to those comments?
So in long-term care, I will echo what Becky said in regards to the uptick in complaint activity. So we, as I said earlier, we have about 1,100 long-term care facilities in the state of Missouri, and we receive about 1,000 complaints a month. So we're looking at investigating about 12,000 complaints a year. So, every single one of those complaints, even if we are not able to substantiate that something has occurred, that is that family member or that resident's reality, right? At that point in time, or that staff member. And so, our enforcement process is different than Mike and Rebekah's. How we write, or our ability to cite different areas is different than theirs. But I think the overarching theme that I see and that I talk to our providers about, because we'll get a lot of questions, right, about why do you think that you are getting 1,000 complaints a month? Like, what is the reason for that? And I think that the overarching component of that is a lack of staff. And I think that it's lack of nurses, lack of nurse aides, lack of folks to work in dietary, lack of individuals to perform housekeeping. There is a lack of interested, qualified, knowledgeable individuals to provide good quality healthcare across the continuum. And that ultimately is, I think, the root cause of many of the complaints that all of us receive. And that is, and for us too, right? I know that Mike and Rebekah and myself, we have vacancies, right? Like we have staff vacancies as well. It's hard to get folks in and trained and to keep them for those 2 years, right? To where they become competent in their job duties. So just, when I think about, the question that you had asked, just regarding, what are the what are the themes, or what are you looking at? That's my main concern.
You just hit a nerve with me, because I mean,
we could all say amen,
things.
right?
Amen for sure.
Every
Mike?
time I think hospitals has it bad, I remember what Tracy's dealing with, and then I feel bad.
No need to feel bad, Rebekah. It's just, I think that, the work that each of us do, Mike and Rebekah and myself and our teammates, it's incredible. Like, I'm so incredibly proud of the work that we do. I mean, do we hit it 100% every time, John? Absolutely not. I mean, there may be opportunities where we need to do better, or maybe we have missed the mark. But we have good, caring, compassionate individuals that are working for us, and they work 365 days a year. Right?
Yeah.
Like, they are on call on the weekends. They're on call over a holiday. They're responding to emergency events in the middle of the night on Christmas Eve. So, I mean, they are just incredible individuals that work within our division. And I think that, that's just, something that I don't think that a lot of people know that.
They don't.
They don't realize that there are, and hopefully they don't realize it because they haven't had to interact with us, right? We have good people. We have great people.
I remember when I used to work for Tracy, I used to carry that beeper, and it would go off at 2:00 in the morning, and you're just like, oh, I need to get dressed and go somewhere. Yeah, I remember that.
Yeah.
But I feel bad for Tracy and Rebekah, because I don't have as many complaints as they have, but I do have enough complaints to keep a couple people busy full time. Like this week, we had 2 complaints investigated. Almost every week we investigate 2 complaints. And when a complaint comes in, it can come in from any kind of source. A member can call me, call my bureau. They can call the abuse and neglect hotline, which is where most of our complaints come from. And we'll triage it, like Becky said, and we'll triage it in different categories. And something that I don't think's been discussed yet, if a complaint comes in and it alleges, abuse or harm or something to that effect, we will triage it at an immediate jeopardy level. And in Tracy's case, we have to be out there within 24 hours. That's correct, Tracy? Right?
So it depends on the allegations. So we can be there. It depends, but we can be there anywhere from within 24 hours to 7 days. So CMS changed. So the federal regulators changed some of our timeframes for us. But generally, if it is a complaint, so if Mike is calling in something regarding his mom, and the facility has not also made a report to let us know that, hey, they had this incident that's occurred, they've begun their investigation, they've immediately put systems and processes into place, and they send us that information. If they don't do that, we will be on site within 24 hours to 3 working days. So we all have short timeframes that CMS provides. So that does keep all of us from being able to do some of our like survey work, because if Mike has or Rebekah has a survey scheduled, and then they have an immediate jeopardy level complaint that comes in that they need to go investigate, it may stave off your ability to be able to do that survey because you need to reroute staff to go look at that complaint. But yeah.
That makes total sense. And really one of the main reasons I reached out to you guys as far as us putting this podcast together is partially because I want to inform the public on what things do rise to the level that they need to call and complain about. Like what are some of those things? And that's probably one of my questions. But before I get into that, let me just say the other half of that is that I really have always recognized that you guys really are kind of some of the unsung heroes, so to speak, like the police officers and, firemen, get all the clout as far as, protecting public safety. But I just don't think the general public understand, who's really, going to go in and look and investigate some of these things. So they're calling the governor's office because they don't know who else to call.
Right.
But at the same time, there may be some people that don't understand what rises to the level of reaching out and saying, "Hey, this isn't good. Can you guys come take a look at this?" Or on the other side, maybe there are things that of those 1,000 complaints or 2,000 complaints that you're getting per month, there may be things that don't really rise to that level. And it's just a customer service thing or something. I want to give you an opportunity to speak to some of that.
Well, for home health and hospice, we really look at how it impacts the patient. Sometimes there's complaints that get called in through the hotline or they call us that really aren't regulatory. For instance, an aide showing up 15 minutes late, something like that. Or they don't like the cologne that someone's wearing, or in an inpatient hospice facility, the food has not enough taste, So we kind of triage that stuff out. And a lot of times we take those concerns and, we'll file them. And if there's enough of them, we'll go in, of course. But most of those things, we say, thanks for bringing it to our attention. And the next time we do a full survey there, we'll look into that a little bit. But we're not going to go send a complaint team in there, for those type of things. Most of the things we actually go on are stuff that for hospice, pain and symptom control, and in hospice, there's a lot of family dynamics too. And it's a holistic approach. For instance, we've had family members that didn't get counseling services that have committed suicide. They weren't, properly assessed for it, things like that. Those type of things we take seriously, and we'll go out there and to see if there's a system failure and look at the effects of the patients to see if they have enough qualified staff, that they're doing the right thing. And we'll, like Rebekah said, make them write a plan of correction, and we'll go back to make sure that they fix that, because we don't want that happening again. And occasionally we cite something, we find something, and we go back and they haven't corrected it. We'll find that they're still doing the same thing, and they're still being patients and families affected. And CMS will say, well, you got one more shot at it, essentially. We'll do a third revisit there. And if they don't pass that, a lot of times they get their provider member terminated and they're out of the program, and they essentially get closed, and we do that. So those complaints are important to call in, because it gives us, the three of us, the opportunity to find problems on someone in the beginning before they get out of control, because we do surveys every year. We try to every year in Tracy's group. We do them every 3 years in home health and hospice. We do them annually in the intermediate care facilities. So anyway, a lot of times those problems start, and if someone calls in a complaint in the beginning, when we can kind of nip that in the bud, it will really save other patients or clients from having those issues moving ahead. So that's my little input on that.
So with hospitals, again, it kind of goes back to, I mean, if a patient or a family member has a concern, even if they file a complaint with us during the triage process, we'll always ask, unless it's super severe or egregious that we absolutely need to go on site for, have you spoken to anybody at the hospital about this? Have you filed a formal grievance? And especially if it's something that's not regulatory, so we're not going to be able to go in and do anything about it. But if they file a formal grievance and the hospital doesn't follow the formal grievance process, that is a standard level tag under the condition of patient rights. So then we always tell them, try to do this. We would rather the hospital take care of it so that they're, number one, aware. And especially, again, if it's not something severe or egregious that we obviously need to go in. Like Mike said, there's a lot of things that patients, family members complain about that is not regulatory. We don't have any jurisdiction or regulatory oversight over billing disputes. HIPAA, we don't regulate HIPAA. We don't regulate physicians per the physician. If they don't like their physician, if they think they're rude or whatever the case may be, if it's just regarding them personally, we don't regulate them. If it was something that they feel they know their doctor ordered something and they didn't receive it, like a medication or a treatment, then that becomes part of the COP, the condition for nursing services, maybe. So it depends on what it is. So then if it is just physician related, we'll refer them to do your due diligence and file a complaint with the Board of Healing Arts. Same thing for nursing. Now, obviously, if it's something that, rises to that COP level, abuse, allegations, any kind of harm, then that's a whole nother thing. We're more than likely going to come in. There's like 26 conditions of participation, and that is for the acute care hospitals. So out of 26, we tend to investigate about 3 over and over and over: patient rights, nursing services, and infection control. Those seem to be the 3 top. When I said earlier, an investigation is different than a survey, we do surveys for those non-deemed hospitals. And if it's a recertification survey to get them certified to continue on having their provider number through CMS, then that involves every condition of participation for that provider type. So we have surveys and then we have investigations. But back to the investigations, the things that we want to hear about are the things that could affect patient safety, harm, medications. If a patient or family member says, I went and visited my sister who's in the hospital, she's got this terrible wound that I know the same dressing is there today that was there last Friday. That type of thing. That's huge. Or my sister-in-law went into the hospital with no pressure ulcers, skin breakdown, and now she's got this huge one. That could potentially be an issue.
Right.
That would rise to the level. But again, that's something, we talk to them through on the triage process. And again, ask them to to file that formal grievance, give the hospital a chance, or if they have. And we ask for them to send us documentation if they have that letter back. And a lot of times they just don't understand. But if it's a situation where it's not condition level and they've done that grievance process, they've received their letters in the timely manner, and the hospital has followed all of what is regulatory per patient rights, then we can't go in because they've done what they should have done. But I think a lot of times the person filing the complaint, they just don't understand that. But that's all that we can ask, because that's all that we would have done was investigated. And if they've investigated, they're not going to share nursing names, exactly what was looked into, but they are going to say if they investigated it. And that's part of what they should be doing.
That's great.
But I think a lot of times that for me, the most disheartening thing with talking with a complainant is when they're very, very upset with the process, or they don't agree with the findings. And again, we send out letters that we have to acknowledge that we received their complaint, and then we send out a finding letter after if it's not going to be investigated or if it has been investigated. We don't give specifics. We can't. All complainants are anonymous. But I also always tell the complainant that's filing the complaint, if it's investigated, we look at a lot of records, we interview a lot of patients, but we do have to focus to get what we need to be able to determine what happened with this complaint. If the hospital figures that out, they do, but we never divulge who that complainant is.
That's good. You protect them.
Absolutely, because we don't want any retaliation to them if they're still there. Staff members will file complaints, and a lot of times you kind of hold them to a higher standard. They're professionals. You feel it should be credible, and sometimes we go in and they're just mad. And that's kind of disheartening on our end, because we've spent a lot of time and effort and money to investigate that, and they really shouldn't have even filed it because they were just mad.
Well, and they took your resources away from maybe a complaint that's legitimate. Yeah,
exactly. But we don't know that until we go in.
Sure.
And I think what I was going to say earlier was the most disheartening thing is when they call and they're so very upset with us for whatever reasons, and get very upset, and they're not very nice. And it's disheartening to me because I know what work our staff does. Like Tracy said, I take a lot of pride in what our staff do. And they're very, you don't go into nursing, or at least 38 years ago, you didn't go into it for the money, for sure. So you go into it because you want to help people.
Right.
And we've got great nurse surveyors, and with the complaint investigation and the survey part, and then we've got great life safety code people that go in and do the licensing and the construction stuff. They all know their stuff. They're very knowledgeable, and they're great people. And it's just hard. I have a little difficulty with that, letting it roll off my shoulders.
Sure.
Because I want to say we do such hard work, and but I understand it's personal to them, and I understand they didn't get in their mind the justice that they're looking for.
Hey, thank you so much for watching this episode of the In Good Company podcast. Make sure you like and subscribe. It truly goes a long way to growing our channel. And also share this episode with someone who needs to hear it most. Now back to the show.
Well, let me just, because we're speaking to the public right now, let me just thank you for the hard work that you guys do. I'll probably say that multiple times through this, but again, and a lot of people experience this. The squeaky wheel is always, or somebody spends more time to give you a bad review than a good one. But it's hard because oftentimes you don't hear from the families that are extremely happy with, your work, because when your job works out great, they don't even know you exist. I mean, that's the hard part about it. And I can totally relate to that.
Right.
Tracy,
and that's not what we do it for. We don't do it for the thank yous, but it's just hard to kind of swallow sometimes.
I can totally understand for sure. Tracy, what are your thoughts around these topics?
Sure. So in long-term care, so when we receive a complaint via the hotline, or if someone's just calls into our office, one of the best things that folks can do is to leave us their name and phone number. So yes, you can report anonymously, right? But if I have the ability to reach out and to talk to you and to be able to obtain additional information, that is going to help us to be able to do a better job. So I'll give you an example. If someone calls in and they're concerned regarding staffing, and they just say, there's not enough staff at ABC facility, that can be really difficult for us to figure out, right? But if I have somebody that I can contact back and say, okay, talk to me about what's going on, what services are not being provided, when do you feel that there is a lack of staff? Well, it's on Saturday evenings, overnights. My mom was sitting wet for 4 hours. That gives us specific time that we would be able to potentially recreate that and be able to have a better investigation. And also it helps us to be able to provide education, because you're right. A lot of the time folks maybe don't know, well, like, are there staffing ratios, or how would I be able to determine if there's enough staff? Is one nurse on duty enough? Is, 15 residents for 1 aide enough? And so just being able to have that conversation and be able to help educate them is so valuable to us. We also will, if it's appropriate, we will refer them back to the facilities. So each long-term care facility is to have a grievance policy and procedure in practice. So where this becomes really important is if you need immediate relief from a complaint, you need to talk to the director of nursing. You need to talk to the administrator, because they can give you immediate relief. If it was a problem with pain medication overnight, if it was a problem with your mom got the wrong diet the day before when her meal tray was delivered, if you go talk to the administrator or the DON, you have a chance for more immediate relief. And oftentimes our staff will ask when they're triaging a complaint, they will say, have you spoken to the administrator? Because we want to make sure that the facility is aware so that they can correct it, because it could be 2 weeks, it could be 30 days before we are able to get on site and to investigate. And we don't want that to continue during that whole period of time. So it's really important, because that gives folks the ability to be able to have those conversations with people at the facility that can help them most. We also sometimes will refer complaints to, or not complaints, but maybe like a situation that maybe could rise to a complaint, or where folks just need some help with advocating for themselves. We will refer them to the Long-Term Care Ombudsman Program. So the Long-Term Care Ombudsman Program, they are advocates for the residents. And so sometimes they are able to help that resident if they're uncomfortable with maybe going to the social service designee or the administrator. They can come on site and be able to help them to advocate for themselves. But yes, we oftentimes will just make sure, have you spoken to the people at the facility that can make an impact right away? We take complaints on everything, if it's regulatory, and just about everything is regulatory, right? So like food temperatures, the quality of the food, the smells of the building, folks having a late shower or non-existent showers. I mean, we we talked about 12,000 complaints, but each of those complaints could have 4, 5, 6 different allegations that are contained within it. So we do get a lot of complaints for varying issues, but would really encourage everybody that's listening to reach out first to the folks at the facility that are able to make immediate change for you. And when you reach out to us, you let us know that you did try that avenue and who you talked to and that it was not successful, because that helps us too to be able to build our investigation when we come on site.
Well, we'll put the phone number to the ombudsman for our area, just to kind of make sure that everyone has that and can kind of start there, along with the state hotline. Are there advocates, other advocates that maybe we can share with the general public that might act more as a liaison with that facility or agency to kind of help them get that immediate issue addressed?
Sure. So a couple things come to mind. One is they certainly can so the long-term care ombudsman program, that would be first and foremost. If an individual has a serious mental illness or an intellectual disability, they can reach out to Missouri Protection and Advocacy. So that is the second agency that they would be able to reach out to. If your loved one has a caseworker, maybe through the Department of Mental Health, because many of our long-term care facilities, it's just not a place for elders to live. There's a wide variety of individuals who need supports in long-term care. And so if they have a Department of Mental Health caseworker, that also is a good avenue for them to use. So I think that probably is the best. And I think Missouri Protection and Advocacy, Mike, that covers for your ICF IID facilities as well. So if advocacy is needed for them.
Yeah. So John, I was going to add on, if someone actually calls in the hotline or calls us from the public, they may have to tell the story a couple times. So if they call the hotline, there's going to be like someone taking the information down, and they're going to send the complaint to the right person. They may send it to Rebekah, they may send it to Tracy, they may send it to me, or others. And they're not experts on regulations. They're just taking the information. And it's very important to be as detailed as you can be with that person on the phone. The who, what, when, where, why, that whole and time. So if they're, the more detailed they can get with the names of the staff, the time that this occurred, the circumstances around it, if there were any witnesses to what happened, those things are very important. And then once I get the complaint referred to me from the hotline, my survey team will almost every time call to get more information, because they know what the regulations are, and they're actually going to be the ones in my area to actually go out and do the investigation. So they're going to ask even more specific questions, because they know what the regulations are and they need to know what to look for. And in the case of the deemed providers, which aren't under our jurisdiction normally, we have to ask permission from CMS to go investigate those complaints. So we need to let CMS know what condition of participation we want to look for or look at, limited to just look in that area. So yeah, the more detailed that you can be when you're calling in a complaint, the better for us. And we can be more effective that way also. And like they said, the anonymous portion of that, we do everything we can to keep the complainant's name away from the facility. We don't really want them to know what patient or client we're looking at. We don't want them to know the name of the complainant. But like Rebekah said, sometimes they just figure it out on their own. But you can call in a complaint and say, hey, I would like this to be confidential. And I just want to reiterate, we try our best to do that.
Yeah, we've experienced that too. If we've had a complaint on our side, and they're very protective of that information. And I don't know that a lot of people know this, but if they call us directly with a complaint, we're obligated to keep a complaint log and then refer that on to the state to report that complaint, so that if for whatever reason it meets the standard, that we need to have somebody come in and take a look at the situation, make sure that it's not a widespread problem, that we have done our due diligence to investigate it and report it to the state. And I'm not sure that everybody realizes, if they call that agency directly, that, at least for home health and hospice, we have to share that on. And I'm pretty sure that's the same for the hospital and the SNF section, right?
Right. Abuse and neglect you're a mandated reporter, all providers.
Right.
Yep.
Right.
So in the hospital setting, Rebekah, do you feel like there's kind of a middle? I mean, you mentioned the administrator. Is there any other groups that you would shout out to say you might try this avenue as well?
Well, all hospitals should have patient advocates.
Mm-hmm.
And so that should be on their patient rights information that's in their patient packet that they get upon admission. That should be listed in there. Hospital rooms now a lot of them have the whiteboards that list their staff, what room they're in, what the date is, who their nurse is, who their aide is for that day, and ask the patient, what do you want to occur today, pain-free or whatever the case may be. Most of the time, the patient advocate is on that as well. But they just need to know that they have a voice, and they need to, like Tracy said, try to get it resolved now. Because once they go through the process, and if it's not at immediate jeopardy level, or an EMTALA regarding an emergency room patient, then it could be a little while before we get to it, based on the volume that we have to take care of.
Yeah.
So,
well, the word deemed has come out just a couple of times, and I figured we probably should just go down this road just a little bit, just to explain it to the general public. So just correct me if I'm incorrect. There's three main bodies that will accreditate an agency or facility, and those facilities or agencies are considered deemed agencies or facilities. And so like we're deemed through the Joint Commission. There's two other advocacy groups. Don't ask me to share their acronym, because I don't know it off the top of my head. But I think there might be a little bit of confusion out there that it's like, well, what does that mean? Are they regulated by the state or not? Well, kind of yes and no, both. And like you'd said, you have to ask permission whenever it's a deemed agency to go in and investigate a complaint. That might be just a little bit confusing. And then, so I wanted to clarify that. The other thing that was mentioned earlier that I don't know that a lot of people know, but you guys are in looking at regulations related to the agency and the facilities themselves. Not necessarily individual physicians or like nurses or therapists, when you're looking at them and their license. So you mentioned the Board of Nursing and the Board of Healing Arts. And so I don't know if you guys can speak to those being referrals that you make. If you get a complaint and then you find something and you're like, ooh, this isn't a process problem. This isn't an agency problem. This is an individual clinician problem.
Correct. So going back to the deemed status for hospitals, there's 4 accrediting organizations.
My mistake.
So for a hospital to be certified and receive their certification through CMS, they can choose the route of being accredited. And so Joint Commission, I have to look at them because I get the acronyms wrong. Accreditation Commission of Healthcare, that's ACHC, DNV, which is GL Healthcare, and then Center for Improvement in Healthcare Quality, CIHQ. See, I always get that one wrong. So those are accrediting bodies that do the recertification surveys, and that is that's a preference by the hospitals. It's not a mandated thing. Not every hospital is accredited, but if they have that deeming status through an accrediting organization, then they do the certifications. We only would investigate complaints based on the authorization of CMS. So we triage the complaint, recommend if we think it needs to be investigated with an on-site investigation, and at what, for what condition of participation. We send that to CMS, they review it, and then authorize it, or they don't authorize it. Then the non-deemed hospitals, like I said earlier, are most often the smaller critical access hospitals. Not always. We have a few acute care hospitals that are smaller, that are not deemed. Then we do those certification surveys. And our workload per se is directed by CMS. So, and it's per tier level. So tier 1 is priorities, any immediate jeopardy or EMTALA investigations. Boom, those are done before anything else. Then the non-immediate jeopardy, non-high complaints, those are done as tier 2s. And then your tier 3 and 4s are your recertification surveys. So those are done about every 3 to 4 years. We need to go in there, and that is, again, a survey that's looking at every condition of participation for that provider type. So it's a big survey. It's usually a bigger team. So that's what that is. Now, a lot of people don't understand too that the state licensure, we have state licensure regulations in addition to federal regulations. And so what we look at on the state side is actually the same conditions of participation that the federals are. And then we have a couple extra, I don't want to say a couple, but there are some extras, state regulations. So there's 2 sets, but the majority of our workload, again, is complaint driven, and it's usually the federal ones. We're going in on a federal process most often.
Okay.
So I just wanted to reassure your viewers here, even if CMS doesn't approve a complaint for us to go in on a deemed agency, they still require a license through me or through Becky. But even if they don't approve it, I can still go in, and I oftentimes do. I'll make it a state-only complaint and go in and investigate that complaint just on state licensure. So just reassure the viewers that yeah, we do take those seriously. And even if CMS has a reason they don't want to allow us to go in, we'll go in anyway. So.
Right. And we can as well, but I'll tell you, I don't want to give a percentage, but it's a high percentage that CMS reviews every single thing we send up, and generally speaking, they usually agree with our recommendation, because I think, we're on the same level as far as we think it's serious enough. Generally, it's going to be authorized.
Yeah, it's very rare that they deny.
Very rare.
Yeah.
Mm-hmm.
John, one thing just to point out for your listeners is that you were talking about the hotline number, and you were planning on to post that. So I actually will send you a link to the hotline reporting page. So it
Okay.
will include the hotline, but then there is also an online reporting form that individuals can use their cell phones. You can use your computer, and you can make an online report. And sometimes that is a better or more efficient way for folks to be able to reach out to the hotline. The hotline does, since it's people answering the phone, it's not available 24 hours a day, whereas that online reporting link, you can make a report anytime. And so you don't have to wait in a queue for somebody to answer your call. You can go ahead and make the report that way. So just wanted to share that there's more to making a hotline than just the hotline number. You can actually make an online report, which is pretty fantastic. And then I'll also email you the link for the long-term care ombudsman program, just in case there are some listeners outside your local ombudsman area.
Yeah.
And that'll include statewide. So they can just get on there, see who's the long-term care ombudsman program in their area, and be able to connect with them. So I'll send those to you via email.
Wonderful. That's amazing. Let me just circle back real quick, because I kind of, when I initially asked the question, I loaded it with a lot of a question in there, and I just want to circle back to it. But when we look at the Board of Nursing and the Board of Healing Arts, those can you kind of help explain why those bodies exist and what they can do to help protect the public as well?
So, and I apologize, I didn't answer that part of your question. You asked it, I just didn't answer that. So if it's strictly about a physician, it's a fine line for us to triage that, because if it's a physician, just their way of how they practice,
Yeah.
that's
Not
us.
customer service. That's
well, not customer service, and it's not us. But if it's how do I explain this? If it's an issue where they feel that they had a conversation with the physician, my mom isn't getting relief from the pain. Is there something else we can do? Okay, I'm going to add in an as needed medication on top of her regularly ordered medication. So if that conversation's been had and he tells the family that this is what's going to be done, and then they are there and they determine, or they can say that it's not being done, then that would be a facility process, a hospital process, because they're not following the physician's orders.
right.
But if it's just maybe a personality conflict or something personal with the physician, that they don't feel that they took their concerns seriously, or whatever the case may be, then it may be something that you need to maybe reach out to the Board of Healing Arts, and they can file a complaint online with them, and then they will look at it. Maybe it was just like I said, they felt they were rude, or they didn't, take their concerns seriously, or whatever the case may be. Really the only time we reach out to Board of Nursing is if we have a abuse, neglect situation. And it's hard to say it out loud as a nurse, because I don't know where things get so bad that it ends up being this way, but we do investigate a lot of staff to patient abuse, unfortunately.
Yeah.
And I honestly, in my heart, don't think that people get up in the morning and say, let's see what I can do wrong
Right.
to hurt someone today. It's just the heat of the moment type situation. But it happens. So if there is a situation where we investigate something like that and we find that it did occur, we are the only agency that can get the ball rolling, so to speak, to put that person on the employee disqualification list. So that's, very important. A lot of times the surveyors are well versed in saying to the hospitals, specifically, you may think you have rectified the problem by terminating that person, that staff member, but they can go right down the street to Hospital B and apply for a job, and no one will know what happened at Hospital A. So that's where we convey to them, we have to know this information. And yes, that's one thing that they are to self-report to us. But that's one of the main reasons. Not only to find out what exactly happened and make sure that the hospital put things into place for to prevent reoccurrence, but to see did that person actually commit this abuse or neglect, and do they need to be on the EDL listing, which we take those very, very seriously. We don't just, anything that we hear want to put somebody on the employee disqualification list, because that's potentially taking away their livelihood. We know that.
Sure.
But if they don't need to be taking care of patients in any of our facilities, then they don't need to be taking care of patients.
Absolutely. That's one of the things, we're talking about vulnerable adults, people who won't complain, maybe be intimidated and concerned, and sometimes recognizing burnout in a clinician that doesn't recognize it in themselves. Maybe how they handle stress isn't appropriate for, working with certain, people. And those are the things that I really, I guess, want to bring to the surface to the general public, is that, everyone should be appropriate, and those agencies, facilities, or whatever need to make sure that they have measures in place to check for burnout, and to make sure that if they suspect something, they can dig in. And, we want to be careful, as you just said, we want to make sure that we are assessing burnout, and that, if somebody's needing to, maybe stay in healthcare, but maybe it's not direct patient care, and they just need a change, then, we're giving them opportunity to do that. But the avenues in which, they can report those things and not feel like they're going to have retaliation, or, create a whole nother problem, because, elder abuse is a serious thing. And unfortunately in this particular demographic, and it's one of the reasons why we wanted to start this podcast, was because I've always felt in my career that these vulnerable adults, unfortunately, as they get older, maybe they get a diagnosis of dementia. When you take somebody's credibility away, and when I say credibility, I try to explain this to my girls. Credibility is something that has a lot of value in society. If you want to be heard and someone believe what you're saying and not just ignore it, credibility is really important. As somebody gets older and they get the label of dementia or whatever, that credibility starts to erode. And therefore, the facility, agency, whoever's working in regulation, we have to double down to make sure that we're protecting people in a variety of different ways. And you guys are key. Like, you guys have people on the front lines to this very thing. And again, I can't tell you how much I appreciate what you guys do enough, because I just don't think the general public even knows how much you guys help protect. And to be honest, when it comes to accountability, we're a local provider. We're clinician owned. We're not owned by other outside entities, that sort of thing. As these big corporations and private equity start buying up healthcare, the accountability factor starts to shift just a little bit. So you have this big company that may own multiple provider numbers in a particular area, and they're just looking at risk management and saying, what's the least amount of care that we can provide and still do business in this area. And if we have to shut it down, we have to shut it down, that sort of thing. I know I'm kind of getting into the weeds here off topic a little bit, but when it comes to accountability, that's something that's always been at the top of my radar, is that, as these healthcare systems, it's hard to know who's local and who's not, who owns them, who doesn't, and how much risk, these big companies are able to keep off of their books, so to speak. Because I've heard of this where, an agency XYZ in our particular area, this has been, more than a decade ago, got in very hot water. They were owned by a huge corporation. The corporation just said, okay, we'll just shut it down. And they just shut the whole agency down. And it didn't hurt their business hardly at all. And it was pretty serious. And so, that accountability side of it is I guess what I'm trying to point out is how complicated it can be.
Yeah, it can be. I think one of the things that is just critically important is whether you have a loved one that is utilizing hospice and home health, or they are in a hospital, or they are in a long-term care facility, you have to be present. I mean, I think that you have to be present, you have to be an advocate, you have to know what's going on. If you have a loved one that's going into a long-term care facility, you know them best, right? Like if my mom is newly admitted into a long-term care facility, I know her best. I know her best now. I know her best at her baseline. And so you have to be present, because if Rebekah's coming in to take care of her and she doesn't realize that, my 92-year-old mom does not have dementia, but all of a sudden she's, talking very delirious because maybe she's experiencing symptoms of a UTI or dehydration or whatever that's going on. Rebekah doesn't know that because she's not taking care of her all the time. She is a new admission, maybe from the hospital, and doesn't know. And so it's just so incredibly important, and to be a squeaky wheel. Like you are your best healthcare advocate. And you need to expect, you have to expect better. And so I think that is just critically important. When I think of some of the situations that we've seen in long-term care over, just even in the last year, new admissions, it's critically important that you follow your mom and dad, or whomever that you are admitting, and that you are truly intertwined in the care that is being provided, and that you are paying attention, that you are listening, that even if your mom who has dementia is telling you something and you're like, oh, I don't know, if she's never talked about someone, touching her in an inappropriate way or harming her in some way, and now she is, speak up, right? Mm-hmm. Just speak up, so that it can be looked into.
Mm-hmm. And I'll add to that, because as sad as it is to say, it happens. And it happens more than you think. And so therefore, those true alleged perpetrators go after that age range, and the patients that are vulnerable because of age, dementia, whatever the case may be, Alzheimer's, because nobody's going to think that they're telling the truth. So when what Tracy said is so very true, and I think it kind of goes back to the staffing. You need to be there as much as possible, because we are seeing issues with staffing. Now, having said that, you shouldn't be expected to do the tracheal suctioning just because you may do it at home, that you're in the hospital environment now, so you're not the care provider. And you shouldn't be expected to, and you shouldn't be expected to be the sitter if that patient needs a safety sitter. But be there, see something, say something, be their advocate.
So true.
So,
So
John, I don't want the viewers or listeners to think that it's just rampant and you shouldn't go to the hospital or go to a nursing home or
Right.
or hospice.
Yes.
It does happen, like Rebekah says, but the thing is, the three of us see the worst of the worst. We spend a lot of
Yes.
energy on that, the worst of the worst. For instance, there's 100 to 120,000 patients a year that sign up for home health. There's like 35 to 50,000 a year that sign up for hospice. And out of that, we may do 2 or 3 referrals to EDL for abuse and neglect, that sort of thing. I know Rebekah does a little more than that, but she sees a higher volume of patients. So, I mean, it happens, but it's not like, I didn't want to scare your viewers or listeners to think that.
Yeah.
Somewhere, because we do background checks and all that kind of thing.
There's a lot of good that goes on as well.
Yeah, a lot of good.
There's
100%.
We just unfortunately only hear about the bad.
Yeah. When you say EDL, can you help the viewers kind of understand what that is? And is that something that's only referred through the state?
Mm-hmm. Yes, it's only referred through the state. We do an investigation. It's separate from whatever investigation we're doing on site. We can recommend it, and then if we find something when we're on site that rises to that level, then we can make that. We're the complainant, so to speak. We put the entry into the complaint system, and then we do the investigation. We send it up to our internal EDL unit. They have a team, legal people that look over it, and then there's a hearing. Usually, it's a long process, and that's even more important for the awareness of us to know about that, to get that started, because it could be a couple of years before it's completed and through the hearing processes, and maybe get them on the list. So in that meantime, they could still maybe potentially work at other places until it's completed. So that's the biggest thing, I think, to take away from all of it.
Yeah.
So EDL, sorry.
Oh, I was going to say, Tracy would be great to talk about this, because there's also other things besides the EDL that people have to check before they hire employees, right?
Yes.
Family care safety registry and
Yeah.
things. I think Tracy would be great to talk about this whole background checks thing.
So real quick on the employee disqualification list. So that's what EDL stands for, Employee Disqualification List. And what that means is that an individual has abused or neglected a resident or a patient, someone within the state healthcare system. And so if Mike or Rebekah or myself, our staff identify that, yes, this individual abused a resident, I'll just use resident for ease, then we can refer them to the employee disqualification list. And that would prevent them from working in a wide variety of healthcare organizations. So they would not be able to work in home care and hospice, or in a hospital, or in a long-term care facility, or in in-home services, or in a Department of Mental Health regulated agency. So it prevents them from being able to work while they are on that list. The employee disqualification list is just one of the background components that regulated healthcare entities are required to check. So for instance, if you want to work in a nursing home, they are going to do a criminal background check through the Missouri Highway Patrol to determine whether or not you have committed a crime against a person. And that's all outlined in state law. And so it specifically says what crimes that you cannot, or that you if you committed it, you would not be able to work in a long-term care facility. And each provider type has different state law that outlines what those offenses are. So criminal background check is one. The employee disqualification check is another. There's also, if you are in if it's been in like a skilled nursing facility and you're a certified nurse aide, and you committed, let's say, abuse while you were acting as a certified nurse aide, and that abuse occurred, you get what's called a federal marker. And that federal marker sticks with you, and your certified nurse aide certification. And even if you try to go work in another nursing home as maybe you're not going to go work there as a nurse aide anymore, but you decide you want to go work in dietary, that marker sticks with you and you are not eligible to work in a Medicaid or Medicare certified facility. So all of those checks, facilities are required to check prior to employing you. So it's important to know that, there are these safety checks that go on. The same with staffing agencies. So each one of our regulated healthcare entities utilize staffing agencies. Staffing agencies, if they are going into a long-term care community, they are required to perform the same background checks and to make sure that the individuals are clear on those areas too. So.
And we look at that on hospital investigations as well. We take a sample of personnel files and we review. And so the hospital is regulated to check those EDL listings quarterly and the background checks, and also ensure that the nurse is currently licensed. So we do a sample. We don't look at every single nursing staff's license when we're in there, but we do a random sampling of that.
Right. Good
And
point.
that would be another way of reaching out to Board of Nursing if we had issues. Because and part of that personnel file review also is looking at training, because the expectation is okay, we get that this is an agency nurse. They're only here for maybe a 13-week contract, but they need to have some orientation to your policies because they are your staff when they're in your four walls of your hospital. That's part of the education component, I think.
That's really good. Let me just put a bow on this, making sure that we're covering all our bases. When we have someone who's coming from out of state into Missouri, most of these background checks will cover anything that has occurred in another state, right?
I believe so.
The federal indicators, like Tracy was talking about, follow you. It's a federal database, right?
Okay.
Yeah.
I guess what I'm getting at is if something happened relatively soon, they decided they needed to get out of town, move to Missouri. I'm just trying to cover all my bases here. Is there any gaps in timing of any of this that providers need to be careful of?
The EDL process takes a little bit of time. You would think, because there has to be legal review of the EDL, because it's a big decision to make, because you're taking away someone's right to work.
Absolutely.
In healthcare. So that process can go anywhere between 3 weeks and 6 months, depending on the severity of it and how long, how backlogged they are and things like that. So yeah, there's a little bit of a gap there to get on the EDL. And the criminal background check, for instance, that Tracy was talking about through the highway patrol, people have to go through the court process. So it won't actually show up as a conviction for an A and B felony or whatever until they've gone through that. So there are some, delays and gaps in there, but employers a lot of times sees that pattern of employment, and they will call hopefully and get referrals from their previous employer to see the terms of how they left.
Right.
Hopefully catch that, but there are some gaps in there, John, from the background check.
I think that's what I was just trying to get at. Is there some extra steps that a provider can do when they have somebody who's freshly moved into Missouri? What are if there were extra steps that we could take to make sure that and not just for us, but for other providers out there, so they're like, okay, maybe we should add this to our list for our recruiters and our HR departments to make sure that we're covering all our bases.
John, I'd have to look back. I think that the state law provides that if it is someone who has resided out of state for a nursing home, I'll double check and I'll email it to you. But I think that there is a provision that they have to do a background screening in the state for which they lived. Mm-hmm. And then if, like, let's say they had a conviction for felony murder or something like that in the state of Kansas, if that, like, you would have to look and see, is that a similar disqualifying crime? And that's kind of easy, right? For like in Missouri, but like you would have to match that up. But I do believe that in the state law that there, for long-term care communities anyway, that there is a requirement if they've moved in state and have lived out of state for a period of time, that it requires you to do either a federal background check or a background check within the state. But I'll look into it and send it to you.
Yeah, no, that's really good. Yeah, boy, we got into the weeds on that one, didn't we?
Yeah, we did.
I'll go down through a couple more weeds. The EDL, that's state process only. So that only pertains to, we can only enforce it to hospitals that are licensed. And we do have a handful of hospitals in the state that are not licensed.
No kidding.
Mm-hmm. Yeah.
Hospitals that are not licensed.
Not licensed, yeah. We still investigate complaints for the federal conditions, but they are not licensed. So you can take my word that we encourage them to check the EDL listing, but we cannot enforce them to.
Interesting. And I'm assuming the non-licensed hospitals can't bill insurance?
No. It has nothing to do with that. And they still are able to, they're certified through CMS. It's just, there's a couple of different provider types that just aren't licensed. It's just for our state laws that aren't licensed. And then there's an acute care hospital that's not licensed that some may think is. So that's all I can say.
Okay.
But we highly encourage, because of the number of potential patients it could affect if they're not doing it. So, and I think over the years we've kind of made our point to where I think they're doing that now.
That's good. Mm-hmm. Mike, you were getting ready to jump in?
Yeah, you were saying if there's other databases, maybe other providers could check. Right. You mentioned that. Oftentimes, even though it's not a requirement, a lot of my home health and hospice providers will check the OIG exclusion list, or Office of Inspector General exclusion list. So they'll check that as part of their background check. And also, it's not required, but a lot of them will hire like a third-party background check company and pay that company to run a background check for all 50 states. Instead of just Missouri Highway Patrol, they'll run it, nationwide. It costs money to have that done. I'm not sure the exact fee, but a lot of the bigger companies will do that. But it's a fee. It's not required to do that, with our state, like I said, but they will do that.
That's a good call out. Yeah, for sure. Just to circle back to my example that I had earlier on the agency that the big corporation basically just shut down. There was like widespread serious problems related to infection control that they were going to get hammered with, and they just basically decided to shut it down. And the viewer might think, oh, well, that fixed the problem, but those clinicians still went to work somewhere and they continued working. And that is kind of one of those problems I just want to point out, that just because the hospital gets in trouble or the SNF gets in trouble or the agency gets in trouble they may fix the procedure. They may fire that person that they think is a problem and say, they can't work in patient care anymore. But that doesn't mean that individual can't go work necessarily for someone else, depending on how that's handled. And that's, I guess, why what Tracy was saying is like, be there, show up, advocate for your people, and be an active participant in the caregiving and healthcare process, because unfortunately, in the world that we live in, as you are dealing with now, you have so many complaints. And you only regulate so many things, and there's not like one overarching body that regulates everything. I mean, one of the not to go down another road here, but one of the biggest complaints that I've had is they talk about waste and the expensive part of healthcare, but yet they didn't empower, in my opinion, our surveyors to dig into the billing side of things where fraud could be potentially happening. And so a lot of the ways in which they look for fraud and abuse is through just pulling charts and looking at how they build things. And if there was actually a connection there between somebody who's actually boots on the ground, going out and seeing patients, and how they're billing things, they probably could uncover a lot more of this fraud and abuse, rather than it, like, the majority of it happens from whistleblowers. And in my mind, it always felt like, so why not empower the people who are already in there doing inspections on quality of care things? There could be another piece of the team that's like almost like a forensic accountant that's going in and going, wait a second, how is this being billed? And is this legitimate? Are these people being put on hospice appropriate? And all of these things that have been coming to the surface where people talk about waste in healthcare, whereas some of that is, in my personal opinion, is just me. This is John Ray talking. That I thought, that would be great if we could empower your teams to be able to do some of that.
Mm-hmm.
Well, John, I can speak to that a little bit. That actually happens. My surveyors will be out there, and myself or whoever, and we'll stumble across something like this. Don't look right. It's like a red flag.
Okay.
This person doesn't need to be on hospice. And then you're seeing the same doctor do it over. We see that stuff.
Yeah.
No, it's not under our purview. We'll take all that information as much as we can, and we'll send that as a referral to the Missouri Attorney General's office and or the Federal Office of Inspector General. And
that's great.
They'll take that information and assign investigation to it, and they'll, like you said, take forensic accounting, folks and things like that. And that's actually yielded a lot of the cases for the OIG and for Attorney General's office. There's been cases like that. I get updates all the time. Some of the biggest hospice issues that come out in that Office of Inspector General report that you saw a couple years ago were Missouri cases that we've reported.
That's awesome.
Yeah, so we do have an avenue to do that, and we take that seriously. I refer probably 2 to 3 cases a year, either to the AG's or the OIG's office.
Mm-hmm.
Well,
same for hospitals as well. We don't, if someone calls in with a complaint and it's really directed towards billing, we don't just say, oh, we don't regulate that. We give them the information verbally on the phone. And then when we send them the letter, we'll have that. We have letter templates that we customize per whatever the complaint is referencing. And yeah, consumer protection hotline, and then the Missouri Attorney General's office for any billing disputes. And then the same thing with the HIPAA, we refer those to Office of Civil Rights, the OCR. So we have, we do referrals. And the same as Mike said, if we're on a survey or an investigation within a hospital and we maybe see something that catches our attention, then, we can take that information and refer it on. So
that's great. That's really good. I don't think I knew that happened as much as you described. So that's awesome. One thing I do want to kind of point out as a side thing, since you mentioned it, Mike, I don't think a lot of people understand this, but when you put somebody on hospice, there is a certain amount of money that CMS, I don't want to say allots, but that's the best way that I can describe it, per patient. And so if an agency puts people on hospice, let's say they don't really qualify for hospice, or they try to qualify them in some nefarious way, and put them on and then take them off caseload after 3 months or something, what happens is that they keep track of the amount of hospice money, so to speak, that person used. And so when they go and actually need hospice, another hospice puts them on caseload, that takes away from the cap that agency is obligated to adhere to. And so there's it's very challenging to explain to people, but basically what it does is it kind of uses up the funding for that person, although a hospice is going to put somebody on that needs it. But what it does is it hurts an agency, because that agency it's almost like a pool of money, so to speak. And so people who have been on hospice and they've used up all that funding will actually take away from that pool. And then people who come on to hospice who've never been on it, and maybe they're only on caseload for about 2 weeks, it adds to that pool of money. And I may have just stepped in it trying to explain something that's very difficult to explain, but it's another reason why it's really important that hospices out there are highly regulated and making sure that they're not putting people on before they actually qualify for hospice, because it ultimately hurts the other hospices out there when these companies are just picking them up and taking them off after 3 months. And we have seen agencies, even in our area, do that, where they've picked people up and taken them off, and it's like almost on a regular basis. And then they come onto our hospice when they actually need it. And that ends up hurting other hospices and our hospice. So I just want to point that out. Mm-hmm. Well, I have taken up an enormous amount of your time, but it has been really amazing. Spencer, what do you have left here?
Well, the only question I have left to kind of close it out is, when you guys think of the future of healthcare in Missouri, what gives you hope, and what do you think still needs our attention?
Boy, that's pretty lofty, Spencer.
I don't think that was on the list.
You're welcome.
Yeah. I'm sorry, Spencer. That was not on the question list.
I'm afraid we're out of time. So,
so one thing that I see is a lot of young folks entering into nursing and things like that. And that, that gives me a lot of hope, right? And you can see that they really care about it. They're not going into it for the money, because the money's not there. They can go work in IT somewhere and double their salary, right? So that gives me hope. One of the things that I think that we really need to be working on is really letting those folks that work in that nursing home, that work in that hospice, that work in that hospital, the workers, to let them know how valuable they are, because the turnover and the burnout is a problem, right? Having consistent staffing and having enough staffing, that's the thing that I really think that we need to work on. And it's tough, because this is a human industry. It's humans, taking care of humans. So it's a tough thing, but yeah, just really putting the value in those folks, I think would solve a little bit of a problem. And I don't always see that, they're just taking the nursing aide in the nursing home for granted. And they are the single, those aides like that are going in and actually touching that patient or touching that resident in the hospital, in the nursing home. To me, they are the most important member of the team. And sometimes they don't feel that way, they feel just and abused, So anyway, that's my 2 cents. That's a personal opinion, of course.
Well said.
Yeah, well said.
I agree with everything that Mike said. And then I think another area other than like the number of individuals that are moving into healthcare as an occupation is another thing that gives me hope is there has been a heightened awareness about long-term care, and there is an initiative that is moving forward to help people see the incredible importance of nursing homes and the people who work there, and changing the face, right? That a nursing home is not somewhere that you go to die, but it's somewhere that you go to live, right? Because that is, they are going there to live. And so that gives me hope because we do have great administrators and nurses and nurse aides and floor techs and housekeepers and social workers and bookkeepers. We have some of the best, most caring people that work in our long-term care communities. And so any way that we can celebrate them is so vitally important. I think that one of the ways that we need to, 2 ways that I think to help us move forward with that, one is leveraging technology. So I think that there is just an incredible opportunity to leverage technology every day. And I'm not talking about like robots taking care of people, because I think we're a long way from there. But there are great ways to use technology in communicating with family and residents, and in scheduling staffing, and using AI in order to help create care plans. Like, I just think that it is endless the ways that we would be able to use that. And then also another area that I see that we need to move forward is truly investing in our healthcare workforce. So how do we bring those nurses back who were tired in 2020 during COVID and decided that they wanted to leave healthcare? How do we get them back? How do we invest in our fantastic nurses that work across our healthcare continuum? And how do we bring some of those folks in who are nurse aides and make them LPNs or make them RNs? And so those are the places that I see that we have to move forward.
All great points.
Can I just say I agree with both of them? No.
Yeah, that works.
I'm the forever optimist. I try to be anyways, most days. And so seeing the younger staff, even when I was a surveyor, I'm thinking, oh my gosh, is this Dr. 12? They looked younger and younger all the time. But that does give me hope that there's still, there are still nursing programs that are full and turning out. If there was any positive to COVID, it taught us that we can do things differently. And to add on to what Tracy said, I think my age, the AI stuff scares me a little just because it's new to me. And I'm learning, but I think that, in healthcare, there's been so many changes prior to all of that coming in. I'm never not amazed at hearing a story of somebody that had gone through a procedure that I've been out of the direct patient care line for a long time. And it's still, I still hear amazing stories. So there's still those things going on. And I've been a nurse for 38 years now. the telehealth, that's something new. I would have never dreamt that that was something that we would be doing someday.
Right.
There's a new thing that was just passed this last legislative session. I can't think of the bill number, but it was a bill for SANE exams for sexually assault victims. Now, because that's a hard thing for a hospital to have a qualified SANE nurse that can do those exams. Now they can do it via telehealth. So it's just, I'm never not amazed with what we can do in healthcare. So I try to remain positive and hopeful that by the time I maybe am a patient somewhere, that it's all going to be good.
Rebekah, I think about hospital at home. Like who would have ever thought, right?
Exactly.
Yeah.
If you'd asked me that 30 years ago, I'd have said, you're crazy.
Yeah.
There's no way. And still when that came out, and we were going through and looking at that, and I had to be on a couple of calls with hospitals that were implementing, it still was so weird for me to understand, how is this really going to work?
Mhm.
I'm not real sure about this, but it's working. Of course, unfortunately now it's on pause because of the shutdown, but try to remain hopeful.
For sure. Well, sorry, go ahead, Tracy.
I was just going to say, do you care if I take a picture of the screen to send to Lisa Cox?
Oh, there you go.
Yeah.
Okay.
Yeah, absolutely. And actually, I was going to say, I hope that you'll get an opportunity to share this podcast with your teams. And, again, that part of this is helping inform the public, but part of it is really to celebrate the great work that you guys do, because I just don't think the general public knows about it. And speaking to answer Spencer's question on my side of things, I think a lot of the complaints about healthcare are directly related to the amount of strain and growth that healthcare has sustained over the last decade. And, growing pains are part of the process. And I think you're right. I think technology is going to help with part of that. I think, new people coming into the system. And one shout out for healthcare, I have never been out of work. Not once.
Exactly.
And I've rode through some very difficult economic times. I'm old enough to have seen a lot. And I never took a cut in pay. I never, was laid off. There's something about being in a profession that is going to continue to grow, continue to be a huge need, and have stability and work alongside people who genuinely care about other human beings and want to do right by other people. And we all got into this for a variety of different reasons, but it's obvious that you guys have passion to try to help other people. And healthcare just attracts this kind of people. And I know we've spent some of this time talking about people who maybe shouldn't be in healthcare, but at the same time, there's 10 times or 100 times more people that are in just the right place. And as much as people complain about our healthcare system, I think it's got so many good qualities to it. And I know our agency appreciates the work that you guys do. I cannot tell you how many times we've had somebody come in and look at our stuff and say, here's where you need to improve things, that we haven't taken that and gone, thank you for, putting us on the right path, making sure that we're doing the things the right way. And it's all good. I mean, because if we can walk away from it a better agency in the end, that's what ultimately matters, because that's why I do this. It's why I'm not selling out to some big, private equity company because they're knocking at my door every week, is because I want to make sure that this company is there for when I need it, selfishly. But also that I have a lot of people that work for me that love this career, that love this business. And, I'm very much loyal to them as well. And so again, thank you for being on this podcast. And as things develop, we may ask you back if that's okay, because there's a lot of changes coming in the next couple of years that will affect healthcare in general, and we'd love to circle back with you.
Yeah. Thank you so much for having us.
Thank you.
Thanks,
Thank
John.
you.
Thanks, Spencer.
If you enjoyed today's conversation, make sure to like and subscribe so you never miss an episode.
And we'd love to stay connected. Follow us on YouTube, Facebook, and on Instagram at In Good Company Elder Care Podcast.
You can also find us on X, formerly known as Twitter, at IGC Pod, and on TikTok at IGC Elder Care Podcast.
Thanks for tuning in to In Good Company. I'm John Ray, and I've been joined by my amazing co-host, Spencer Ernst. Special thanks to our executive producer, Alex Wallace, for helping bring this show to life. Until next time, take care, and remember, you are always in good company.